What if I told you that a simple pill could help you lose over 13% of your body weight in just 64 weeks? Sounds too good to be true? Well, the latest NEJM study on oral semaglutide 25 milligrams might make you think twice. But before you get excited, there are some critical limitations we need to discuss that could change everything. Welcome back to MedJournal Club, where we critically examine the latest medical research that impacts your practice. Today, we're diving deep into the OASIS-4 trial published just last month. This study examines oral semaglutide at 25 milligrams for weight management, a lower dose that promises similar efficacy with potentially better tolerability. But as always, we'll separate the hype from the science. Let's start with context. The global obesity epidemic is real. We're seeing rising prevalence worldwide with limited effective treatment options. Current GLP-1 receptor agonists include injectable semaglutide at 2.4 milligrams and oral semaglutide at 50 milligrams. Here's the key issue. Patient preferences strongly favor oral over injectable formulations, but the existing oral dose comes with significant gastrointestinal side effects. The OASIS-1 trial demonstrated that 50 milligrams oral semaglutide works, but nearly half of patients experience nausea, and about 15% discontinued due to adverse events. This creates a clinical dilemma. We have effective treatments that patients struggle to tolerate. Enter the OASIS-4 trial, testing whether a lower 25 milligrams dose could maintain efficacy while improving tolerability. Before we dive into the study, let's quickly review semaglutide's mechanism. It's a GLP-1 receptor agonist. Think of it as mimicking your body's natural incretin hormones. Available as Ozempic for diabetes, Wegovy for obesity, and Rybelsus as the oral formulation. What makes semaglutide special is the pleiotropic effects. It doesn't just help with weight loss. We're seeing blood pressure reduction, cardioprotective effects reducing major cardiovascular events, renoprotective benefits slowing chronic kidney disease progression, and emerging evidence for neuroprotective properties in Alzheimer's and Parkinson's disease models. However, and this is crucial for today's discussion, gastrointestinal side effects remain the most frequently reported adverse events across all formulations. The central research question is straightforward. Is oral semaglutide 25 milligrams once daily more effective than placebo for weight reduction in non-diabetic overweight adults? The hypothesis was that this lower dose would provide significant weight loss with potentially improved tolerability compared to higher doses. Simple question, but as we'll see, the implications are far more complex. OASIS-4 was a phase 3 multi-center, double-blind, placebo-controlled randomized trial, the gold standard for clinical research. The study enrolled 307 adults from 22 sites across 4 countries over 71 weeks total. Participants had BMI of 27 to 30 with obesity-related complications, or BMI 30, and importantly, they were non-diabetics. Here's where it gets interesting. They used a 2-1 randomization favoring the treatment group, with 205 participants getting semaglutide and 102 getting placebo. The dose escalation was methodical, starting at 3 milligrams, then 7 milligrams, 14 milligrams, and finally 25 milligrams over 12 weeks. This careful escalation strategy was designed specifically to minimize those problematic gastrointestinal side effects we mentioned. The average participant was 48 years old, and here's the first red flag. 80% were female and 90% were white. Only 8% were Black participants. The mean BMI was 37.6, with waist circumference of 114, systolic blood pressure of 131, and HbA1c of 5.7%. This demographic composition immediately raises questions about external validity. Can we apply these results to the diverse patient populations we see in clinical practice? This limitation becomes even more significant when we consider obesity disproportionately affects certain ethnic minorities. The primary endpoints were percentage weight loss and achieving at least 5% weight loss at 64 weeks. Secondary endpoints included various weight loss thresholds, plus BMI reduction, waist circumference reduction, blood pressure changes, HbA1c reduction, and adverse events. This comprehensive outcome approach is actually a strength of the study. Rather than just looking at average weight loss, They examined clinically meaningful thresholds that correlate with health benefits. The 5% threshold is particularly important because it's associated with improvements in cardiovascular risk factors. Now, for the results that generated all the headlines, mean weight loss was 13.6% with semaglutide versus 2.2% with placebo, an 11.4 percentage point difference that was highly statistically significant. Nearly 80% of semaglutide participants achieved at least weight loss compared to just 31% on placebo. The higher thresholds are equally impressive. 63% achieved at least 10% weight loss, 50% achieved at least 15%, and nearly 30% achieved at least 20% weight loss. These are substantial effects. We also saw significant improvements in BMI reduction, waist circumference, systolic blood pressure, and HbA1c levels. All efficacy outcomes achieved statistical significance with a 79% completion rate, indicating good study retention. But let's talk about safety, because this is where things get nuanced. Any adverse event occurred in 93% of semaglutide participants versus 85% on placebo. However, serious adverse events were actually lower in the semaglutide group, 3.9% versus 8% with placebo. The predictable culprits appeared: nausea in 47% versus 19%, vomiting in 31% versus 6%, and diarrhea in 18% versus 9%. Interestingly, COVID-19 was reported in 21% versus 18%, suggesting that some GI effects might be related to concurrent infections. Discontinuation due to adverse events was remarkably low, only 6.9% versus 5.9% with placebo. The study has several notable strengths. First, robust methodology. It's well-powered with high completion rates and appropriate statistical handling of missing data. Second, comprehensive outcomes measuring multiple clinically relevant endpoints beyond just weight loss. Third, high treatment adherence with 94% completion and 81% reaching target dose, demonstrating the regimen's feasibility in practice. However, several critical limitations demand attention. First, limited generalizability. The predominantly white female cohort raises serious questions about applicability to diverse populations. Second, no active comparator. We can't directly compare this 25 milligrams dose to existing 50 milligrams oral or 2.4 milligrams injectable formulations, limiting clinical decision-making guidance. Third, missing data concerns. 20% didn't complete treatment, requiring statistical imputation that may affect validity. Fourth, industry sponsorship by Novo Nordisk raises potential bias concerns. Finally, subjects were followed up in the medium term only. We lack long-term safety and efficacy data beyond 1.5 years. So what does this mean for clinical practice? This provides a new lower-dose oral semaglutide option with similar efficacy to higher doses, potentially improving tolerability and adherence. The cost-effectiveness angle is particularly interesting. A 50 milligrams tablet could theoretically be split for 25 milligrams dosing twice, though this isn't officially recommended. This expands patient choice between oral and injectable GLP-1 agonists, but we still need head-to-head comparisons. The question isn't just whether 25 milligrams works, it's how it compares to existing options in terms of efficacy, tolerability, and cost-effectiveness. The bottom line is this: oral semaglutide 25 milligrams demonstrates clinically meaningful weight loss with an acceptable safety profile. However, the limitations are significant: limited diversity in the study population, lack of active comparators, and industry sponsorship concerns. Here are the key questions for your practice. How might this change obesity treatment algorithms, given the similar efficacy but potentially better tolerability? What factors will guide your choice between 25 milligrams versus 50 milligrams oral formulations? And critically, how do we address the generalizability concerns when treating diverse patient populations? What's your take on these results? Do you think the benefits outweigh the limitations? Drop your thoughts in the comments below. And if you found this analysis helpful, smash that like button and subscribe for more evidence-based medicine reviews. Until next time, keep questioning the evidence and improving patient care.